All right, I see it.
Good.
There we go. And so I want to preface my talk with the fact that there are a variety of learners in the audience. Some social workers, some nurses, maybe some physicians or pharmacists. And so it was somewhat difficult to know exactly how much neurobiology and neurochemistry and whatnot to include. And so as we walk through this, if there are parts that, mean less to you, that's okay. But if there are parts that you don't understand and want to learn more about, please just feel free to chime in with a question. There's plenty of room and time for questions. And so I know I was slightly introduced, so just so you know my background, I am an internal medicine provider, which means I'm basic primary care, but I did do a fellowship in addiction medicine. I'm an assistant professor of medicine at UAB, which means that I am both a physician that sees patients, and I see patients about half time, and then I am also someone who teaches young doctors how to be doctors. And then I help lead things up at Beacon Integrated Healthcare with the help of wonderful, wonderful people here that I couldn't live without. All right, so our objectives today in this talk is that by the end of this talk, you will be able to describe the brain disease model of addiction, that you will recognize the implications for treatment and treatment advancements, that you will explore how selected available treatments align with the brain disease model, and you'll be able to compare how we view addiction treatment to the treatment of other diseases. And so the outline is somewhat like this. We're going to start with reviewing brain neuroanatomy and the changes that occur during addiction. Again, this is going to be a little bit nerdy, and if it doesn't resonate a ton with you, that's okay. If by the end of it you don't remember the specific names of the specific brain structures, that's also okay. I myself have to relook them up sometimes. But essentially, the areas of the brain involved in substance use disorder, and you'll hear me sometimes flip back and forth between substance use disorder and addiction. Traditionally, NIDA, which is the National Institutes of Drug Abuse, which is kind of like the CDC for addiction, will refer to severe substance use disorder as addiction. And so if you hear me go back and forth, that's NIDA lingo sneaking in. So when we think about substance use disorder, there are several parts of the brain that are primarily involved, and it can affect multiple parts of the brain, but the primary ones involved are the basal ganglia, which you see here, which plays an important role in positive forms of motivation, including getting pleasure from normal activities like socializing, eating, sex, things like that. And it's involved in formation of normal routine habits, like once you get in the habit of running and running feels good to you, that euphoria that you feel is partially through the basal ganglia. It's an important part of the reward circuit that gets circumvented during drug use, because drugs overactivate this circuit, and repeated exposure diminishes its sensitivity to pleasure of normal things that would be pleasurable. Another part is the extended amygdala. This plays a role in stressful feelings like anxiety. This is more your fight or flight section of your brain. It can lead to anxiety, irritability, and unease. This is where withdrawal happens. Withdrawal tends to be a highly amygdala activating area. This circuit becomes increasingly sensitive with increased drug use. And over time, a person with substance use disorder uses drugs just to get the temporary relief of all the activation of the extended amygdala. Another area of interest in substance use disorder is the prefrontal cortex. The prefrontal cortex powers our ability to think, plan, and solve problems. It helps us make good decisions and exert self-control over impulses. This is the last part of the brain to mature during adolescence. And so I know Ashley mentioned that in October there's a session on adolescence and also sessions on the family, and that's very important because early substance use really impacts the prefrontal cortex for reasons that we'll talk about later, since it's still developing. And what happens is with repeated substance use, the prefrontal cortex can become fixated on the relief of the feelings that occur in the extended amygdala. And that can lead to preconditioned drug cues such that, even seeing a street where they used to buy drugs at will make them start the process of sort of feeling high and etc. And when we think about brain activity, it's important to know that brain activity starts in a neuron, which will then send cells through this transmitter axon arm through chemicals called neurotransmitters to a receiving cell. And some drugs, like heroin or marijuana, can activate neurons. They can activate that receiving cell down here because they look exactly or very similar to the neurotransmitter that is normally present. Unfortunately, since they're not exactly the same, it creates aberrant drug signaling, which actually can even stimulate changes in that receiving neuron. Other drugs like cocaine or methamphetamine actually act at what we call the presynaptic neuron, so the one sending rather than the one receiving. This little space here is called the synapse. And cocaine and methamphetamine act up at this sending one and cause it to release far more neurotransmitter than it normally would. And because the amount of the neurotransmitter, even though it's the same neurotransmitter that's normally there, because the amount is so high, it again creates aberrant signaling and diminished responsiveness to normal amounts of neurotransmitter. So what does that look like at a cellular level? So this is looking at dopamine in that synaptic space. So in this little space right between the two neurons, that's what's being represented here and here. And you can see that with normal stimulation, so something like eating food that can be pleasurable for eating the things we like, there is some dopamine release into the synaptic space, but compared to what happens during cocaine use, it's a very small amount of dopamine. Cocaine use causes massive amounts of dopamine to be released, which will ultimately make this cell less responsive to the dopamine that's present. So that's what's going on sort of at the chemical cellular level. And then what happens to these receptors over time is that there's then pruning of the neurocircuitry. And so as we develop, we have lots of connections between all of our different neurons. So one neuron might connect to 4 different neurons. Oh, there's lots of hand raising. Oh, good morning. Okay. Was there a question? Maybe not. Okay. Chat box said someone raised their hand. But over time, as one pathway gets used a lot and other pathways don't get used, the pathways that are used less are pruned. So that would look something like this, where this neuron used to connect to a whole bunch of others. Now it only connects to 2. And not only do the pathways get pruned, but sometimes the neurons get pruned. So see, there used to be 3 neurons in this row. And, of course, this is just a drawing, but still, there used to be 3 here, and now there's only 2, and there used to be 4 here, and now there's only 3. And so what can happen over time, what this is designed to do is to make our brains more efficient. And it's supposed to produce really smooth flowing and beautiful neurocircuitry that is artistic almost. But what can happen is when this pruning occurs in the setting of drug use, is that pathway that occurs between the extended amygdala, the basal ganglia, and the prefrontal cortex can consume most of your neuro pathways, and the ones that are used more for other coping skills and reasoning skills can get pruned. And what happens is instead of being this beautiful, efficient brain, we end up with a brain that has trouble performing other functions besides this drug reward pathway. And it's pruning that we didn't necessarily want, but we just got. And this happens, of course, more the more drugs you use and the earlier that exposure occurs in life. So what does that look like on neuroimaging? So we don't necessarily see the pruning, but what we will see on neuroimaging is decreased uptake of different chemicals. And so this is PET scanning. So this measures metabolic activity in different areas, and these are the dopamine producing areas of the brain. And so this is measuring dopamine receptor in the striatum. So that's sort of down where the basal ganglia is. And what you can see is in a normal person, there's a lot of dopamine receptors and receptor activation going on. And this is a person who's now abstained from cocaine for about a month. And so this person, you know, the only stimulus for their dopamine receptors is life and how happy they are to be there participating in research during the PET scan. And similar for this person, they have the same amount of, you know, mediocre stimulation during this scan. And you can see that there's far less dopamine receptor activation. And even 4 months out, that remains less than a comparison subject. And so just because someone's abstinent for 1, 2, 3, or even 4 months doesn't mean that we should expect them to remain abstinent or to have an easy time remaining abstinent, because their brain neurochemistry really hasn't returned to normal just yet. In addition, the pruning process will take even longer to readjust. So what does that mean for our patients? Well, I know I am preaching to the choir quite a bit with this group because this is the Addiction Prevention Coalition, but prevention is really key. Preventing pruning is better than trying to repair it. Any early intervention we can do to try and prevent early adolescent or childhood drug use is extremely powerful in preventing those pathways from being pruned at that early age when the prefrontal cortex is yet developing. And in fact, this is from the NIH, and it's available on the NIDA website. It's literally called Principles of Substance Abuse Prevention for Early Childhood, a research-based guide. And I don't know if you guys are familiar with the NIDA website. It's drugabuse.gov, but it has a plethora of really user-friendly brochures like this. In fact, all the images I used for the past few slides came from their brochure about addiction as a brain disease. And so I just really recommend checking out that website if you're ever trying to explain this phenomenon to friends or colleagues, or if you want to look at some early interventions that you might want to consider trying that are going to be based on research and research data. And I know I've sort of harped on this, the changes that occur during substance use. And so I did want to emphasize, though, that with treatment, we can help people get better. And so I know I showed the one with cocaine use at 1 and 3 months and 4 months, sorry. But so this is someone with methamphetamine use. Again, here's a healthy control. Here's 1 month of abstinence. Here's 14 months of abstinence. And so brain function can return to close to normal or even normal levels, but it does take quite a long time. In fact, this is, you know, part of the reason why we see recommendations in the NIDA core principles that treatment, for instance, like residential treatment, should be at least 9 months. That's its recommendation. I know that's not what happens often, but it's because the brain just doesn't return back to normal quite so quickly. And again, these images are showing the density of dopamine transporters in the brain to illustrate the brain's ability to recover, at least in part, after prolonged periods of abstinence. Here we go. And so now we're going to discuss some selected pharmacologic treatments based on the brain disease model of addiction. So there are 3 FDA-approved medications for opioid use disorder. This graph depicts those 3 medications. All 3 medications work on the mu opioid receptor in the brain. So they work on the same receptor in the brain that heroin or other opioids do. They function differently at the receptor, though, and I'm going to explain that here real quick. So methadone is what we call a full agonist or full activator of that receptor, meaning if you give more methadone, you can ultimately get full activation of the opioid receptor like you do with heroin. And you can, in fact, get respiratory depression and overdose if you give enough fast enough. We tend not to do that in methadone clinics, and that's why it's monitored in methadone clinics, and we don't just prescribe it from a clinic because a person could take too much on their own. But then when they're in methadone clinics or federally registered opioid treatment programs, they're observed so that that doesn't happen. Buprenorphine also works at the mu opioid receptor. It also activates it, but it has a ceiling effect, meaning no matter how much buprenorphine you give, you'll never fully activate the mu opioid receptor. It does also work at other receptors. And so in general, given at pharmacologic doses and taken at pharmacologic doses, patients who are not opioid naive will not overdose on buprenorphine. They will not have full respiratory suppression if they're using buprenorphine alone. It is possible to overdose with buprenorphine in combination with other drugs. And when I say overdose, I'm referring specifically to respiratory depression. Can patients take enough buprenorphine that they get loopy and confused? Oh, absolutely sure they can. But what we're really talking about is prevention of death. And so since it's unlikely to die from buprenorphine at prescribed doses, it was deemed back with the DATA 2000 waiver safe enough to be prescribed through a regular office clinic. And so that's where we have buprenorphine clinics. The third medication used for the treatment of opioid use disorder is naltrexone. Naltrexone blocks the mu opioid receptor, so it doesn't activate it at all. It just sits there and blocks it. And that means that when they do, if they were to relapse and use an opioid, they don't feel the positive effect, and they begin to lose that circular pathway of drug equals reward. There's also a theory that just the receptor being blocked will help decrease cravings. So that's the 3 drugs for opioid use disorder. I will also add that you'll often hear patients sometimes will talk about buprenorphine naloxone, aka Suboxone, that the naloxone is the blocker and that's what makes it work and that's what makes them sick. But in reality, buprenorphine has a higher affinity for the receptor than the other opioids. And so what that means is that even if someone is on methadone or on oxycodone or heroin, if you take buprenorphine too close to that, the buprenorphine itself will kick that other opioid off the receptor, and it will drop a person from this high level of activation to this mediocre level of activation, and they will get what we call precipitated withdrawal, and they'll feel nauseous and vomit and things like that. Patients often think that that's the naloxone part of it, but it's not. The naloxone is actually not absorbed if it's taken sublingually. The naloxone is only there to prevent patients from injecting the pill or the film. All right. And so some people feel like using buprenorphine or methadone because they're activators of the receptor is just replacing one drug for another. We hear that a lot, and we hear even patients are concerned about that. But this is a graph of opioid receptor activation over time. And you can see that there is a huge difference, even though both methadone and heroin fully activate the receptor. There's a huge difference in how that receptor is activated. So when a person uses heroin, in a very short period of time, they have full activation of that receptor, and then it wears off shortly thereafter. So within 5 hours, usually within 3 to 4, the person is having withdrawal from heroin or is at least having decreased effects. Whereas with methadone, it almost takes 5 hours to get that receptor activation. So it's a very slow onset, very slow offset receptor activation. And that is what helps people stabilize on methadone, even though it is still activating the same receptor that they activated during substance use. So if you can imagine, if we think back to the parts of the brain, I'll just go back real quick on my slides so that you can see those. So with heroin, the person's going to spin through sort of the basal ganglia, amygdala, prefrontal cortex circuit really fast because they're going to get intoxicated and have all this reward. And then within 5 hours, the extended amygdala is going to be all activated and in withdrawal and upset. And the prefrontal cortex is going to begin to perseverate on renewing getting rid of the amygdala activation that's uncomfortable and renewing the high. And it doesn't leave a lot of time in the day to think about other things like getting a job or coping skills and things like that, because that onset offset happens too rapidly and too much throughout the day. When you compare that to methadone, where there's just this sort of smoldering activation of the basal ganglia such that they can avoid that extended amygdala activation that's uncomfortable, then their prefrontal cortex can think about other things other than just relieving discomfort. Similarly, buprenorphine is also very slow acting and slow wear off, but it doesn't fully activate it, and naltrexone blocks it. So what does that mean as far as outcomes? So this is just a graph comparing all medications for opioid use disorder to no treatment. So if we were to use the general population's mortality rate as the reference point, patients who have opioid use disorder who do not receive medication-assisted treatment, so when it says no treatment, it means no medication, will die at about 6 times the rate of the general population. If you can put that person on medication, then they die at just under 2 times the rate of the general population. Does it reduce it to 1? Does it make it normal? No. That's because it doesn't work for everyone, right? Like there will be some people who will get on medications and still use opioids, but it is way better than no medications.
Hey, Dr. Laish, we actually have a question in the Q&A, and the question I do believe is regarding medication-assisted therapy, but the question is, what if alcohol is the drug of choice?
We're coming up on that.
Okay.
Yeah, we're coming up on that. All right. And so just one more slide on opioids, and we're going to talk about alcohol, or a couple more slides on opioids, and we'll talk about alcohol. So just another one. Sometimes people sort of have this thought like, well, it'll get them to live, but will they just be living and using drugs? Well, some will, but a lot less will use drugs if they're on buprenorphine than if they weren't. And if you look at this other 2003 study, there was only about 20% of patients in that study remained positive for opioids, whereas those who were in the placebo arm all continued to use opioids. So a big difference there. And this was another study looking at placebo versus buprenorphine, and what this showed is that over the course of a year, there were 20 patients in each arm, so 20 in the placebo and 20 in the treatment arm. And of the 20 in the treatment arm, about 15 of them remained in treatment on buprenorphine. And those who were given placebo very rapidly fell out of treatment. And so what we know is over the course of the year, for those who were on treatment, about 75% of them submitted negative urine drug screens, meaning it was positive for buprenorphine and buprenorphine only, and not positive for other opioids or other drugs. You'll notice that the control group number is missing, and that's because they fell out of treatment, so they didn't submit any urine drug screens. We can guess that at least a percentage of them were still positive for opioids, but we don't really know. In addition, the buprenorphine group had a huge reduction in the addiction severity scores. So if you're not an addiction researcher or someone familiar with that, this addiction severity index, or the ASI, is this, it's a little like the ASAM in that it asks about a lot of different dimensions and then scores how much addiction is impacting their life in regards to employment, relationships with other people, et cetera, et cetera. And so they had a much less impact in the buprenorphine group. The other thing is this study actually took a little heat, because in this control group, they were able to follow through the National Death Registry the fact that 4 out of the 20, which is 20% of the patients in the control group, died. And so some people said, well, that was unethical to allow them to die when methadone was available at the time, and they could have put them on methadone as a comparator instead of placebo. But the people who designed the study designed it this way because at the time in the country that it was done, there were a lot of requirements to get on methadone. For instance, you had to fail abstinence-only approaches at least twice. And so these were people who had not yet had 2 attempts at abstinence only. And so they were being treated in the control group like they would normally be treated in that particular country. And it was associated with a 20% mortality. Okay, so how effective is buprenorphine when you compare it to medicines, other commonly used medicines? So for the providers or pharmacists, or even people in the room who might have personal experiences with these drugs, if we compare it to like a statin, which is a cholesterol medicine. So cholesterol medicine in a patient with coronary artery disease or with heart disease, and we're trying to prevent one death using a cholesterol medicine. This NNT is the number needed to treat, which means the number of patients that you have to put on a cholesterol medicine to save one person from dying is somewhere between 30 and 100, depending upon the study. If you take a person who has high cholesterol but hasn't had a heart attack and you're trying to prevent a heart attack, you treat over 100 people before you save one person from a heart attack. And this is very common in medicine. Most medicines have a fairly high number needed to treat. If anyone's ever been in the hospital and you were put on that blood thinner to prevent you from getting a blood clot, that's what PTE is. We have to treat about 40 people to prevent one blood clot. If you are placing a patient with opioid use disorder on buprenorphine to prevent them from dying, the number needed to treat is 4. So 1 out of every 4 patients that you treat with buprenorphine will live because they were put on buprenorphine. And so that number is much lower than other commonly used medications. I will use this often to demonstrate to my prescribing colleagues how effective this medicine is, and also to talk about sometimes providers will admit a person to the hospital who is on buprenorphine but is still using drugs. And we say like, well, I don't think buprenorphine works because that person was on it and they were still using drugs. But we admit people all the time to the hospital who are on cholesterol medicines and still had a heart attack, right? In fact, 99 out of 100 of these people are still going to have a heart attack despite the statin. Similar with, insulin diabetes, like we admit people all the time who are on insulin and are still having complications of their diabetes. That doesn't mean that we stop their insulin. It means that maybe we just need to adjust something. And so I think that's just an important way to sort of reframe our brains when we think about medications for opioid use disorder. And the reason it's important to reframe our brains is because this was a lovely study done in 2018 by Dr. La Rochelle up in Boston, where they compared incidence of mortality after a non-fatal opioid overdose for patients who were given methadone, buprenorphine, or naltrexone compared to those patients who were given nothing. And what you can see is that their incidence of mortality is much, much, much lower. So again, this is like the 1.5 times normal versus 4 to 5% all-cause mortality. But what was somewhat disturbing about this study is that 85% of people fell in the given nothing category, and only 15% of people were placed on medicine. So if you, again, could compare to other diseases, can you imagine if someone was admitted for a heart attack and we only treated 15% of them and the other 85%, we were like, wow, that's bad. Here, go home. We wouldn't accept it for other diseases. And so I'm an advocate for making sure we don't accept it for opioid use disorder. And I call this the badness that we need to break. We need to stop allowing people to walk out with no treatment. So what if the drug of choice is alcohol? There are 3 FDA-approved medications for alcohol use disorder. I'm not going to talk a ton about disulfiram today, which is antabuse, and that is because it does not involve neurochemistry, and so it doesn't fit with like the addiction as a brain disease model, but I'll tell you a little bit about it. Disulfiram is a medicine that it stops the breakdown of alcohol midway. And so people build up a toxic metabolite if they do drink alcohol, and then they get sick right away. And so that will help stop the circuitry because there's no longer reward from that pathway. There's, in fact, adverse reactions. In fact, nausea and vomiting is one of the most significant adverse reactions people can experience in regards to learning. If something makes people nauseous, they will not touch it again. And so that is how disulfiram works. The other 2 we're going to talk a little bit more about because they work directly on the brain and brain chemistry. One medicine that's approved for alcohol use disorder is naltrexone. It may sound familiar to you because we just talked about it for opioid use disorder. What's impressive is that naltrexone is FDA approved for opioid and alcohol use disorder. It's also shown efficacy in methamphetamine use disorder, cocaine use disorder, and gambling use disorder, and some compulsive sexual behaviors. And part of the reason we think it shows that efficacy is because it is this opioid receptor blocker. And so we think that just its presence on those opioids helps decrease the prefrontal craving pathway. In addition, when people drink or gamble or use cocaine, that euphoria tends to operate through endogenous opioids, and naltrexone will block those as well. So even the opioids that our body makes, naltrexone will block. And so there's decreased response to any kind of drug cue. And so that is used for alcohol as well. The other one that we use is a camprosate. So what happens in alcohol use is there is a alteration of the homeostasis of what I like to think of as an inhibitory neurotransmitter called GABA. So this is a neurotransmitter that makes people kind of sleepy, kind of relaxed. And then glutamate. Glutamate is an excitatory neurotransmitter. And so this causes excitement, irritability, at high enough levels, seizure. And what happens in alcohol intoxication is that GABA is increased. So alcohol works on the brain and increases your GABA. And initially during intoxication, there is then relatively less glutamate and it results in sedation, right? When patients do this over and over and over, the body compensates for that by increasing the amount of glutamate around, so that patients who have chronic alcohol use will have both increased GABA and increased glutamate. This is what we might think of as tolerance. And then if we abruptly take away the alcohol, which normally would increase that GABA, the GABA goes back to normal a bit quicker than the glutamate can, and that's why withdrawal is manifested as excitation. So that tremor, hypervigilance, anxiety. And so that's why when we're treating withdrawal, we always have to treat it with things like benzodiazepines that help increase GABA and calm the system down. So a camprosate is a medicine that helps to increase GABA. It is GABAergic. In addition, it can help modulate or moderate glutamate, meaning make it a little bit less, so that it can help even out this homeostasis. It's not potent enough that it can be used for the acute withdrawal state, but it's mild enough that it can be used long-term to help the patient not be seesawing and having the cravings associated with having this increased glutamate level. And so a camprosate has been shown to increase abstinence and decrease severity of relapse. Oh, there's lots and lots of things in the chat. There's like 11. Ashley, can you let me know if there's a question in there so that I don't know?
Yeah, so one of the questions that someone had mentioned was when you had mentioned that naloxone works with gambling addiction. Can you talk a little bit more about that?
So it can help decrease compulsive gambling. Naltrexone, not naloxone, naltrexone. Did I say naloxone? No, it's okay. Maybe I said it wrong, but it should say naltrexone. Yeah, naltrexone. So the difference between naltrexone and naloxone is naloxone, one, is not as orally bioavailable. So if you were to take naloxone into your stomach, it doesn't absorb well. So that's why we can actually, it's funny, we use oral naloxone to treat opioid-induced constipation, because if you take oral naloxone, it just stays in your gut and acts there. And so it will decrease opioid-induced constipation, but it won't get into your system and knock the other opioids off the receptors. And that's why when we use it for reversal of an overdose, we use it in the nose because it's actually atomized to absorb through the nasal mucosa. The other thing about naloxone is it's much shorter acting than naltrexone. Naloxone will only last for like 30 minutes to an hour, whereas naltrexone will last a much longer time, hours to, if you use the injectable version, weeks. And so it's naltrexone that we tend to use for alcohol. Interesting preliminary data out of Canada would show that oral naltrexone is as effective as injectable naltrexone for alcohol, where that is not true for opioid use. But yes, there does seem to be some help with compulsive gambling. Now for gambling, cocaine and methamphetamines, the studies that have been done so far have been small and have shown somewhat of a small impact. And so it's not yet where it's statistically significant enough that the FDA has said, yes, we're convinced this works. And so it's not considered an FDA approved medicine for those indications. It's only FDA approved for alcohol and opioids. But for my patients who have co-occurring disorders, I tell them, hey, if you're using methamphetamines and opioids, we know it will help with the opioids and it might help with the methamphetamine cravings as well. So try and frame it like that. All right, so that was pharmacologic interventions. There are 3 other drugs that are approved for substance use disorder treatment by the FDA. Does anyone know what other condition we have drugs for? So we talked about drugs for alcohol, drugs for opioids, opioid cessation. What other cessation might we want to help patients with? Smoking, that's right. So tobacco, alcohol, and opioids are the only ones that have FDA-approved medications to help with cessation. I didn't put the smoking cessation medications on here today just because I feel like they've been around long enough that we're mostly all familiar with them. But just in case you wanted to know, it is nicotine replacement, bupropion, which is Wellbutrin, which is an antidepressant, which will help with smoking cessation. And it used to be varenicline. There was recently an FDA recall of varenicline. That's sort of still like a hot topic because that was very, very recent. But those were the 3 that had FDA approval for smoking cessation. All right, and then there are some non-pharmacologic treatments that are based on the brain disease model. I'm just going to talk about a couple, and then I'm going to turn it over to Bronwyn to talk about other things in more detail. The one I wanted to share about is one of the ones that's most studied for stimulant use disorder, and that's because I know that stimulants are sort of on the rise, and stimulants are a huge problem here in Alabama at the moment. All right, so contingency management. And again, I recognize that many of you are from backgrounds where you may be even more familiar with this than I am. I'm just going to give the brief outline here. Contingency management is a proximal positive reward for specified desired behavior. So desired behavior is assessed often, and if present, is rewarded in close proximity to the behavior. And prizes increase with sustained behavior. So what does that look like? Well, in the clinic that I used to work in, it looked like this. We would tell a patient, hey, you're going to come and you're going to give a urine drug screen every Tuesday and Friday. And if your urine drug screen is negative for cocaine or methamphetamine, whichever one they've been using. So we used it a lot for cocaine because this was in the Northeast, and that's what they used the most up there, more than amphetamines. If it's negative for cocaine, then we'll give you $2. If the second time it's still negative for cocaine, we'll give you $4. And then it'll be $6, and then it'll be $8. But if it's ever positive for cocaine, so say on that 6th week or 5th week, it's positive for cocaine, then you don't get any money that day. And the next time you give one, you're back at $2. And so there's kind of both an immediate consequence for negative behavior and an immediate reward for positive behavior. And that's designed because a lot of the rewards for sobriety actually take a lot of time to come to the patient, right? In fact, early sobriety kind of sucks for a lot of patients. There's just a lot of work they have to do, a lot of reparations, and their dopamine is very low. And so it's a very sad and kind of icky time. And so having these proximal positive rewards can be helpful. Another way this is done is with what we call the fishbowl approach. So similarly, you would pick a behavior, and that behavior can be a urine drug screen that's assessed. It can be, hey, you're going to show up for your appointment. It can be whatever behavior you specify, but you're encouraged to pick one specific behavior. And then you reward it right when that behavior is assessed. And in the fishbowl approach, each consistent appropriate behavior results in them being able to pick more of these papers from the fishbowl. And the papers from the fishbowl, like there might be 100 in there, and 60 of them will just have positive comments that are like, good job, keep up the good work, way to make progress. And then 40 of them might have $1 or $2, or 30 of them might have $1 or $2, and 10 of them might have $20 or something. And so their chances of getting a bigger prize increase the more little fish tags they can take. So that's another way to do contingency management. So sometimes I hear like, that's just wrong. We're paying them to not use drugs. I want to be paid to not use drugs. People get kind of upset about this, but in reality, if you compare the cost of contingency management to the cost of other treatments, it's a relatively cheap treatment. And so depending upon which route you use, so like the $2, $2 one that I demonstrated, even if the person completed our thing, ours was, I want to say it was 8 weeks. Even if they completed it, the most they could make was like $160. And so divided out over a month, it's less than $100 a month. SOAR 2 funded programs are actually limited to giving patients $75 a year. And part of that $75 a year is because the government argued that it's actually a violation of the Stark law because it's a kickback to get paid to not use drugs. If you compare that to something like naloxone, where it's $40 a dose, or Narcan if you're naloxone for an overdose, it's the generic, that's misspelled, sorry. Generic is $40 a dose, the brand name is $130 a dose. If you compare it to Vivitrol, we love Vivitrol. Vivitrol is $1,200, $1,500 a month. Compare it to insulin, so just another disease, depending upon their dose and their type of insulin, it's $50 to $300 a month. A cholesterol medicine, again, is more expensive. Chemotherapy, for sure, more expensive. And then prison time, because that's an alternative way we give people drug treatment, right, is over $2,000 a month for one inmate. So really comparatively, I'd rather pay people to stay out of jail and not use drugs, $100, $120 a month, than to pay for them to be in jail. Yes, and I see someone saying it's common that when people abstain from alcohol, really, or any drug, that they'll transition to another addiction. Yeah, and so that, I think Ronald will touch some on like teaching other coping skills, because if our neurons are pruned in a manner that we don't have any coping skill but chemical coping, all we do is hop substance to substance, or even substance to like behavior, because some people will develop eating disorders and things like that. The other behavioral intervention that's shown to have a lot of efficacy for stimulant use disorder is community reinforcement. I'll be honest, I welcome all the tips from the counselors in the group about community reinforcement approaches. I read several articles about it to try and figure out exactly what is contained in it. And it sounds like it's a little protean, but tends to involve most often either an IOP type setting or a residential type setting where there's a lot of involvement in a structured type environment that's collaborative, and it's a collaborative approach between providers and the patient, and it may involve some role playing, and it'll begin with a functional analysis of their drug use and their sober behaviors. So like, what leads you to drug use? What leads you to these other sober behaviors? What are the benefits of this? What are the benefits of that? And we'll also involve this behavior chain analysis. And so they'll do, it's where they ask the patient, from the time you thought about using drugs to the time you used it, what were the steps involved? Like, did you have to pick up your phone? Did you have to look through your contacts? Did you have to travel somewhere? Did you have to take a bus? And what they're trying to do is to turn it into as many possible discrete choices, discrete opportunities the patient has to make a different choice, and to make those individual opportunities as transparent to the patient as possible, so that they can, anytime they think about using drugs, have multiple opportunities to change their mind. And so that's an example of behavior chain analysis. For one VA study, which used a residential treatment combined with something like AA, so it was like a 12-step program, they had a 90% success rate at 2 years, 90% absence rate at 2 years. In addition to the AA type 12-step meetings, they also had skills training focusing on problem solving, communication, and drug refusal. And so really all that to say, what community reinforcement is trying to do is trying to take this pruning that has occurred aberrantly and to restructure it into the pruning that's supposed to occur. Because if we just take people off of drugs, if we just have them be abstinent, even if you put them in a locked unit and have them be abstinent for 3 months, their brain is still like this. The pathways are still wrong. If you let this tree just grow like this and you don't address the imbalance, it's just going to keep growing imbalanced. And so community reinforcement is trying to fix that pruning. And so in the last couple minutes, we'll talk about just some comparisons between substance use disorder and other treatments or other diseases, because I like to put things into perspective for providers. I don't know if you guys know this, but it's something like less than 5% of primary care providers are buprenorphine licensed. So less than 5% of primary care providers are available and willing to treat opioid use disorder, which is not enough. So if we compare opioid use disorder to or drug abstinence to other behaviors that we commonly treat in primary care, patients are as likely to adhere to recommendations to avoid drugs as they are to adhere to recommendations to avoid salt for hypertension or carbohydrates for diabetes. Sorry, I got that in reverse. This isn't supposed to be hypertension diet, it's supposed to be diabetes diet. And so it's not like drug use is so much more difficult to treat. Sure, the consequences look different and the stakes can be more immediate than with hypertension or diabetes, but patients are just as likely to adhere to our recommendations in other diseases as they are in substance use. In addition, patients are far more likely to receive evidence-based treatment for other illnesses. You can see here in this lovely CDC graphic that if someone has diabetes, the vast majority of those people, 85% of them, will receive appropriate treatment. It's still a little bit sad in our country that 15% of people will not, but at least 85% of them get treatment, whereas compared to substance use disorders, only about 10% of people will receive evidence-based therapies for their disease. Again, this is just a reminder that compared to other commonly prescribed medications, buprenorphine for opioid use disorder is highly effective. And then sometimes providers are reluctant to treat substance use disorders because they feel like it's just too hard. And patients, there's so little recovery. And while it's true that 40 to 60% of patients with substance use disorders will relapse to substance use, that's very similar to patients with hypertension or with asthma who will get on treatment and then either have dietary or medication indiscretions and have a relapse of their hypertension or their diabetes or their asthma. So relapse rates are pretty similar. And so we shouldn't give up on our patients just because they sometimes relapse to drug use. So all that to say, in summary, like many other conditions, addiction is a treatable chronic relapsing disease. The pathophysiology tends to affect the brain circuitry involved in reward and decision-making, and treatments that focus on these pathways and help to undo pathologic pruning will aid in recovery. And now I have it open for questions.
Wow, thank you so much. That's such great information. If any of you guys have any questions, if you will either drop them in the Q&A box or the chat. We have Dr. Lesh for a few more minutes, so we will get her to answer those questions.
And if you don't have a question at the moment, if someone would be willing to throw me like what your background is and what you found helpful or useful in the conversation, that would be fabulous, because this is my sort of beginning foray into presenting to non-physician audiences. I speak a lot to physicians, but it's always difficult for me to know what everyone else is interested in learning or hearing and where they're coming from.
Of course, and I will actually send that feedback information to you from the evaluations that they'll do. And then you'll be able to see kind of what their background is and then just their feedback and what they're interested in. So, but it does look like we have a couple questions. One is it possible if someone is going through withdrawals of alcohol that they can manage this on their own?
So it would depend on the severity of their withdrawal. And there's actually a clinical decision tool that's used called the Prediction of Alcohol Withdrawal Severity, or the PAWS score. And you can Google that and you can help them calculate it. I'll actually even put it in the thing here, PAWS Prediction of Alcohol Withdrawal Severity. And patients who score high on that should be admitted for withdrawal. Patients who are lower on that can be treated outpatient treatment of alcohol withdrawal usually would it still involve seeing a provider for medications like benzodiazepines or gabapentin. People who score really, really low, we can sometimes tell them to cut back their drinking over time. We never recommend people to abruptly stop drinking in a non-monitored setting.
All right, great answer. And the next question that's in the Q&A is, do you have any information on the effectiveness of treatments that are virtual or digital based versus inpatient using MAT? If not, what are your thoughts on that?
Say the beginning of the question again, virtual versus digital based MAT. I'm sorry.
Yes. Do you have any information on the effectiveness of treatments that are virtual or digital based versus inpatient using MAT?
So versus inpatient. So outpatient treatment specifically for opioid use disorder, there's no evidence to say that inpatient treatment is more effective. In fact, inpatient treatment is less effective than outpatient treatment in general. Even so, during COVID, they did some about telemedicine. Now I don't have information on like entirely virtual, like where you don't speak with a provider at all. Like I don't have any on artificial intelligence care, so to speak. But if we're talking about telemedicine, outpatient care versus inpatient OUD care, telemedicine outpatient care is still more effective using MAT than inpatient care. The problem is a lot of times when we talk about inpatient care, we're talking about 3 days to maybe 2 to 7 weeks of treatment. It's a long time if someone stays in treatment for a month from an inpatient standpoint, but in reality, that pruning's not getting fixed and the dopamine's not better in a month. And so holding them inpatient doesn't necessarily change that. I'm not saying that there are no benefits for people with very unstable home environments. It can be great to have a period to help stabilize those social factors. But unfortunately, we see too much cycling in and out of these very short inpatient stays, and that does not produce long-term sobriety.
All right, and last question that we have right here is Valium a common medication to give to someone to handle withdrawals?
To handle benzodiazepine or alcohol withdrawal, not opioid withdrawal.
I do believe, yeah, alcohol, based on the previous question that was asked. Yeah, alcohol.
Okay, yeah. Although I see patients all the time, and this is something where we do try and educate patients. I had a patient who we see it both ways, right? So some patients are coming off of alcohol and their well-meaning friend will give them a Lortab or some heroin and say like, oh, this will help you get through. No, it won't. Opioids will not help you get through alcohol withdrawal. And you can still have a seizure and life-threatening arrhythmias. So they need to come on into the hospital. In addition, I have patients who have opioid withdrawal and a well-meaning friend will give them like Xanax. Like, well, that might help with some of the anxiety associated with opioid withdrawal, but it's not going to help with the diarrhea, nausea, vomiting, and all those other things. And so it's just important that your patients understand that the drugs don't really work that way. Another common thing, and I want to let Bronwyn go, is a lot of patients think that using a stimulant with opioids decreases their risk of overdose because they're like, well, if I use an upper with a downer, then I even it out. And that's actually not true. Using stimulants with opioids increases your risk of overdose because the theory is there's increased cardiac demand at a time of decreased oxygenation. So although it's a theory, we know for a fact from drug death data that using the stimulants with the opioids increases the risk. It's funny, I actually had a patient, I explained that to a patient because he was like, I'll only use meth to help me not overdose. And I was like, actually, you're increasing your risk of overdose. And he's like, wow, you just saved me a lot of money. It's like, well, that wasn't my goal, but I'm glad you're going to not use that meth anymore.
All right, awesome. Thank you so much. We're actually going to take a couple minute break. So if y'all want to come back at 12:05, we will get started with Bronwyn's presentation. Thank you, Dr. Lash.
Thank you.
Yeah, I want to say thank you so much, Dr. Leish. I thought you were great and so helpful, so much needed information. And just looking in the chat, a lot of people are really grateful, thankful for just you spending your time and showing some of the differences, the medications. I know as a non-medical provider, it's always helpful to me to hear directly from the doctor, the provider, about the differences, why you're making the decisions you're making. Sometimes, we're just all doing our own thing, and it's helpful to take a time out and to hear. And you've gotten a lot of thank yous in the chat and people saying where they're from, and they're representing nursing, medical social workers, new to substance use counseling, and working in homeless services. I know you wanted to kind of get a view of where people are coming from. And I think this is the only down side to Zoom. I think we'd have a lively discussion on a few of these things if we were in person and people would get to really share on some of those. Because I think it's just really interesting information when we look at and really challenge the stigma of addiction and how it's not so different behaviorally from other disorders that people have and from other compliance rates. So that was great data for us.
Thank you. And I'm excited to hear you also. I'm going to stay on while you talk because it's also good for me to hear.
Yeah, it's good to share
what you do. Yeah. I mean, I know vaguely about it, but similarly, I prefer to know more and just learn. Mm-hmm. Thank you all.
Thanks, Ashley. Thanks for starting us off, Dr. Leish. I really appreciate it. I know that your time is valuable and limited, so thank you. I reached out to Dr. Leish and asked if she would do this, donate her time to the Addiction Prevention Coalition. Thank you, Ashley, for being the great producer today. Just thanks for the APC for all of your great work. And I know we were all ready for our September. It's recovery month, and I know we wanted to do the great rally in the park, but the Delta variant squashed us. So thanks, APC, for still celebrating and just allowing us to do this, to still have some ways to get together and talk about addiction and recovery. So I'll do part 2, which is about the therapy component. How do we take the science? How do we take the research? How do we take what we know about the brain and utilize it in day-to-day therapeutic interactions with our patients, clients, customers? I know we have a lot of different things that we call them. And I do think physician work is therapeutic with our clients. I'm just going to distinguish that when I talk about therapy as, non-physician work. So that's what we're going to talk about today. And who am I? Who cares what I say? So my name is Bronwyn McInturf, and I direct addiction services in the Center for Psychiatric Medicine. I have a bachelor's degree in psychology, and I have a master's degree in social work. I've worked in this field for over 20 years, and 20 of those have been right here in addiction recovery programs at UAB. I'm not a person in long-term recovery. I always say that because I know a lot of times many wonderful people in recovery do work in the field. And that's just not part of my story. So what draws me to this work? What has kept me here for so long? I am a strong ally for many friends, family members, the community of people in recovery and people who are in active substance use disorder. I think what draws me in and has drawn me in is what a difference I see that recovery can make, what a drastic difference that recovery can make, how exciting, challenging, inspiring it is to be a part of that work and that journey. It's just kept me in it. I was going to do this for a very short term, and here I still am and loving it. So what do we do here? What do I do at UAB? So these are just the programs that I work with. So we do inpatient detox, as Dr. Leish said and talked about. There are times when people need 24-hour management of withdrawal symptoms or acute intoxication. We have an intensive outpatient treatment that's for those with insurance or who can private pay. And we have a sister organization, Beacon Recovery, that is for those who do not have insurance or the ability to pay. So we have both of those programs. I don't manage the Beacon program, but I just wanted to mention that they're on this continuum as well. We offer continuing care for those who have been through treatment, as Dr. Leish said, with the pruning that goes on. We know if somebody is going to maintain recovery over time, it's going to be a journey that's not just a couple of days inpatient, a few months in an outpatient treatment program. So our continuing care program offers weekly group for up to 2 years. Family services, we do healthcare professional evaluations. We have a large consult service that goes house-wide and sees any patient that that there's a concern for a substance use disorder or that has a substance use disorder and wants resources or needs specifically an addiction medicine physician to look at the case. And Dr. Leish helps with that consult service as well. We have I guess you would call it a partnership with transplant services for heart and liver. So we look at the patient, their story, and their risk for relapse as their transplant teams look at if they're a good candidate for transplant at that time. We have peer support, and some of our therapeutic offerings within our treatment program are EMDR, DBT, CBT. We have a CSAT on staff, and in non-COVID times, we do some fun equine therapy, which is great in our experiential modalities. So that's some of what we do. So today, as we said, we'll talk about clinical care, direct therapeutic care that is informed by research, informed by the science. And I like to look at what do we need to address generally, like if somebody comes into treatment, how do we treatment plan? As Dr. Leish said, let's look at what's happened to the brain, what's happened to behavior because of what's happened to the brain, and how are we going to help this patient determine their goals, help them achieve those goals. So what are we going to address? And then how do we get there? So I like to use the 6 dimensions as my guide. There's lots of other content areas, but for me, it's just been a really helpful way to organize and for us as a treatment team to organize our thoughts and sort of have different buckets of what we may look at with this person when we're treatment planning, and then what specific skills we need to use within each of those areas that we're targeting. And we talk to the patients about this as well. Of course, we look at them with them at their goals and how it fits into these and what we can help them with. So I think probably everyone here, you know, the 6 dimensions. We don't have to go over those, but just in case, if you need a refresher, I put them up as we'll be talking about those today, and we'll be matching skills to these dimensions or therapeutic interventions to these dimensions. And as you can see, I have a line drawn through dimension 2. I'm still going to talk about dimension 1, although I think Dr. Leish really covered that beautifully in terms of all of the therapeutic and the medical, I guess you would say, tools that we have to address dimension 1. And then, you know, we had to not really talk about everything. So dimension 2, just sort of outside of the scope of today. So these are generally what we're going to address when someone is in treatment with us. So dimension 1, every practitioner, well, not every, but a lot of the evidence-based guides out there, a lot of the academic approaches are going to talk about dimension 1. You can hear Ernie Larson talk about stage 1. You can hear Paul Early in Recovery Mind Training calling it containment. Gorski, you know, talks about this stabilization. And that's a have to, right? When we have someone who's ready for treatment, we're looking at somebody basically in crisis and with a very small window sometimes of opportunity. And sometimes in a life or death crisis, depending on the drugs that they've been using, how much over time, and the mental health issues that they may be having. I think we're all familiar with the mental health crisis that can accompany substance use disorders. So we see a lot of folks come in who are suicidal, homicidal, engaged in some kind of self-harm. So what do we have to address first? We have to address those immediate needs, stopping the cycle of, as Dr. Leish described it, the using, depleting the dopamine, feeling awful, using just to get a little bit of relief, the shame and guilt that goes with that, because I've intended to stop. So I use more, little bit of relief, feel awful, shame and guilt. So we can do that in a number of ways. She talked about the medical, and sometimes the containment can be through inpatient hospitalization just as an immediate need. I know that's not effective long term, but sometimes it's needed in the short term. And it looks like somebody raised their hand. Lane Davis. Anyone? Okay, well, feel free to ask any questions at any time or interrupt me. I forgot to say that at the beginning, but I know I'm here not really lecturing to y'all, but discussing with peers and just presenting information, but I consider y'all all experts as well. Okay, so we've got to stop that wheel from turning. So that's our dimension 1, and we can achieve that as we've talked about in a number of ways. And in that dimension 1, what we want to do as well is start to introduce recovery basics, the idea of what sober support is. And I mentioned this last one, the structured style. There's some good research out of Texas Tech and the wonderful people there that looks at the correlation with what happens and what kind of person and what kind of program is able to maintain recovery for the long term. And they're actually pairing some of those behavioral studies now with brain studies, which will be really interesting. So they're looking and doing, and I'm not sure what brain scans they're doing, but of people in long-term recovery, like over 30 years. So what happens to your brain on recovery? But this structured style, to me, is a part of Dimension 1. It's a part of stopping that. And we do talk about substance use disorders, but I slip into saying addiction as well. So how do we stop that addictive cycle? And structured style simply means structure. And there's a strong correlation. So it doesn't mean one causes the other, but there's a strong correlation with people who adopt a structured style in their recovery, a structure to their day, a structure to their support meetings, spending their time in meaningful ways. So a structured style. So that's all that means. So this is all Dimension 1 items. Any questions?
Bronwyn, this is actually a question that was left over in the chat from Dr. Leish's presentation. Just wondering if there's any studies that correlate between those who have substance use disorders in a recovery, yet are living with other people that have substance use disorders. What's the success rate or relapse incidence rate? Sorry.
That's a wonderful question. Thank you for whoever asked that, because that is the reality of so many of the people that we work with, is that they're attempting, they're in a community where many other people have a substance use disorder or use without a substance use disorder, and they're attempting to enter recovery. I don't know about that or research on that specifically. What I do know is there's a lot of research looking at placing sort of the opposite, putting somebody in sober living. And again, the sober living, if you kind of look at this Dimension 1, helps folks establish recovery basics. It provides sober support and that structure. And so there is a lot of research out there that sober living contributes to short-term and even long-term success in recovery. But I don't know if they've done sort of the opposite study of looking at people who tried to maintain their recovery while living with other people that are using. But I think we can extrapolate that if the research shows you have a higher recovery rate when you go into sober living, probably you would have struggles. As we're going to look, Dimension 6 is recovery environment. So it's a very important piece of what we address. Thank you. I love questions. Dimension 3, as we said, we're going to skip 2, not because it's not important. It's just sort of outside of the scope of today and outside of my expertise. So feeling and dealing with emotions. Look at our little friends here. This is a lot of big emotions. In active addiction, many people use drugs or alcohol to deal with feelings. And so as Dr. Leish said, I know there's the pruning that happens from a neurobiological perspective. And I would posit that happens behaviorally as well. People also just get used to one way of coping with feelings, which is drinking and using, right? And so they may not have the experience of tolerating emotions, experiencing emotions, exploring those. And that's a big part of what treatment has to do. As we know, one of the outcomes of having a substance use disorder is the inability to even name emotions. So People make fun of us therapists because we have those feeling wheels that we look at and those emotion charts on your office wall. And if you have those, just let me validate you. Keep those up there, even if people tease you, because our clients need to see that. They need help naming, exploring, understanding emotions, and tolerating those. What you're going to find in folks with early recovery, and I'm sure you know this, is that there will be a lot of swings, and those swings won't necessarily be between highs and lows of emotions, although they can, but a lot of times they're going to be swings between intense emotions and numb. So I don't know how many of you work in the treatment world, but I'll have someone come to me and they've just met somebody in treatment 2 days ago and they're the best. They're my best friend. I love them. We're together forever, or if somebody does something to them, they just get so mad. They want to punch a wall. And then other days, just numb. And I put it out there to the group, which do you think is more upsetting to our clients to experience, the numb or the highs and lows? If you just want to put that in the chat. What do you think our client, numb, Derek Johnson, you get a gold star. You were number one to answer. That's right. Feeling numb. Have I done something to my brain? Will I ever be able to feel again? As Dr. Leish said, the beginning of recovery can be yucky. And as we sometimes call it, they get into the recovery sucks mode. This sucks. And the numbness, the inability sometimes to experience those normal emotions can be very setting. And as we know, there's a neurobiological reason for that, but there's some behavioral reasons as well that we therapists can help with. Okay, dimension 4, we have to address where somebody is, their stage of change, but I'm going to include in this, part of it is we help them with motivation, but also hope and self-efficacy. The belief that I can do this, that is so important for us to address with our clients, that we instill through skill training, which we'll talk about, but also just the belief that I can do this. So skills help somebody believe they can do it, but also working with them on motivation and hope. Have any but one of you ever run into a client who just says, I want to, but I don't think I can. I've relapsed so many times. I don't know that there's hope for me. How many of you run into a family who says, I don't think there's hope for them? They're coming here to treatment again. I don't believe it. They're never going to be able to do this. There used to be the saying in the community, once an addict, always an addict. And some people still believe that. So for me, one of the biggest things we have to do as we work with them on motivation is instill hope. And so it's not a technical part of dimension 4, but I'm going to include it because I get to, is spirituality. I think that's a huge part of the treatment of substance use disorders. And I'm not necessarily talking about religion, although for many people that is a part of their spiritual practice, but it doesn't have to be. And as clinicians, we, and I'm sure you all are, have to be sensitive to that and aware of that. But I think it's a part of this hope and a part of moving people through the stages of change is spirituality. And when I talk about spirituality, I'm going to include personal connections. So connecting to other people other than oneself, connecting to a healthy way to interact with people, and connecting to something bigger than ourselves. And we'll talk about later, how do we do that? How do we do that while respecting that, you know, we're not going to get into the religious realm because that's outside of the scope of what a lot of us do. But how do we help people connect to something bigger than themselves? It's a big part of what we have to do. This is a big part of what's on our treatment plan. And just looking at people talking about Al-Anon, helping the family. Yes, family work is a big part of what we, how we address some of these different dimensions that we will talk about. So connecting to other people helps stimulate our reward center. That's our slow reward center, right? Drugs and alcohol stimulate that reward center that is very quick, that's necessary for survival. Food, sex, water to quench our thirst. Drugs and alcohol tap into that quick reward center. Interactions, healthy interactions with other people tap into that slow reward center that can help somebody through the recovery sucks stage until their dopamine system has returned to pre-morbid state, returned to normal. And we know that that return to normal can take up to, and I don't emphasize this with my patients because they say it's scary, but it can take up to 18 months. We know from scans that look at the ability to produce dopamine. Sometimes dopamine neurotransmitters can be damaged from drug use, but that's a whole nother talk. The ability to produce dopamine, we know, kind of is back at about 80% for most folks at a year. So that's the good news. But what can we do with hope, motivation, spirituality, and again, healthy interactions with other people, healthy interactions with something outside of ourselves. And for many of our folks, that can mean doing something good in a group and not just for yourself. Any questions or comments there? All right, we're on to dimension 5. If our dopamine system has been compromised, we've had that neural pruning and we've had that behavioral pruning, how likely are our folks to relapse, get back into old behaviors? If you just want to put in the chat, really likely, not that likely. I don't know if anybody's ever gone on a diet where you tried to cut sugar, carbs after, let's say, 20, 30, 40, 50 years of eating the same way. It's hard. And we're very, very likely to shift into some old behaviors. Well, so are our clients. They're no different from us. So yeah, everybody says very likely. Yes, you are right. So treatment has to teach relapse prevention. Everything fits into relapse prevention. And this is why people come to us for treatment, right? They want to make a change and then maintain that change. So this is what we do. This is it. This is the big banana here. And so relapse prevention has some very specific meanings. We do assessment, we do skills training in a very specific way to teach patients, as Dr. Leish was talking about, behavior chain analysis, breaking things down to a very granular level, teaching people drug refusal skills, teaching people to identify relapse warning signs. Terence Gorski's method is one that we use here and have studied. But relapse prevention can also mean anything that makes your life better, and that helps you not go back to using and drinking, right? So I want you to think about that in some very specific ways, and we'll talk about those skills. We'll get specific, but also just think about it as the big picture. And finally, oops, just did a little bad thing there. Finally, dimension 6, I don't have as much here. We're not going to talk as much about it because this is its own lecture, but recovery environment and doing family work. We have to address this. The great person who asked that question of how likely are people to recover if they're living around other people who are still engaged in drug and alcohol use. You know, just the face validity of that is not very likely to recover. It's hard. So every treatment program that wants to help people maintain change has to address the recovery environment. And the family work, you know, when I use that family, the term family, and that's the way we use it here, to anybody that's important in that patient's life. That could be a blood-related family. That could be a close-knit set of friends. I remember it was years ago, we had a therapist come to us, an older therapist. Her parents had passed. She had no close family to her, and her family was her group of other older women who were therapists as well. And that was her family. And they're who came in and did the work with her. They had done the intervention with her, and they're the ones in her recovery environment who we did the work with. So don't feel that you're limited if somebody doesn't have, you know, a biological family. All right, any questions on that? Okay, so we've got our treatment plan, right? We know what we're going to do. Now, how are we going to do it? That's the next part. So this next slide is really based on the work of a great guy. If any of y'all have gone to SUDs in the past, you've seen him, Merrill Norton. Dr. Norton is has his doctorate in, he's a pharmacist, but he's also director of a treatment program. He does a lot of research on drugs in the brain, what happens chemically, and he's also done a lot of work translating how we can make use of the pharmacology, the neurobiology in treatment. So this stuff, I know it seems very, you know, simple, but it's very important. So how do we get there? The first thing is just sort of the approach. And our approach has to be, he calls it, and I call it, low and slow. That doesn't mean that we're condescending to our patients. That's not what I'm talking about. But we're understanding that what's happened to their brain is not insignificant. And the behavior patterns are not going to be easy to break. We know that concentration, memory, attention can all be impacted by the way we feel, by that withdrawal process. We know that emotions can impact the way we think and process information. And coming into treatment is a great thing. It really is, y'all, but it's also a crisis. So if we inundate somebody on day one with, well, let me just give you all these pamphlets on your disease. You need to read and study this. I'm going to have you read the first 165 pages of the big book. You're going to go to a meeting tonight, call your sponsor, and tomorrow I expect your step one. Not going to work. And I used to be the counselor that would do that. Okay, so I've got on your treatment plan, you know, these 20 things we're going to do. No. Overall, we're going to keep it low and slow, simple things. If we're working with somebody on our consult service as much as possible, but also with our outpatients, I write things down. So I introduce myself. I'm your counselor. This is my name. This is my role here. And I give them a piece of paper with that same description. Sounds simple, but it helps calm their anxiety. It helps orient them. And again, in the moment, their emotions may be so big, or their post-acute withdrawal may be so big that they're going to need that reminder. And so we engage others as well. If somebody's coming in and they have a family, I'm going to give that same information to their family. Generally speaking, when we approach treatment, see, hear, do. So that's from neuro-linguistic programming. If we want to help somebody make a change and maintain it and teach new information like skills, ways to stay sober, ways to communicate, we're going to have to engage them in multiple different pathways. So we're going to give them something to read. We're also going to present that information in a lecture, and then we're going to do it. And I cannot emphasize enough the importance of the doing. So if you just want to take, I kind of gave you the answer here, but just tell me quickly in the chat, how do you accomplish that doing in treatment? Those of you, because I know a few of you are practicing right now in treatment programs. How do we help somebody? We know how to do the see, we do, the hear, lecture. How do we do the do? All right, y'all, you staying silent out there in Zoom land. 2 people raised their hand. I don't know how to. Action, small, discrete tasks, be reliable, live up to your word. Good. And we do the actual activity with them. If I tell you to go to a meeting and get a sponsor, or if you're going to Smart Recovery, you're going to get a mentor. If you're going to Christian Celebrate Recovery, you're going to get an accountability partner. I'm going to tell you to do that. And then we're also going to role play it. Okay. So tonight at the meeting, I'm going to be the person that you've been thinking about as an accountability partner. And I want you to be you and come up to me. How are you going to ask me to do that? We're going to role play a difficult conversation. You live with a bunch of folks and they don't have an alcohol use disorder, but they're still drinking. And it's really important to your recovery, that they not drink around you anymore. So let's role play that. So we do it. Back in the day when we had a residential program, we would take patients to meetings, right? You take them to all these different meetings, then you come back and you process that. So if we want somebody to learn meditation, which we'll talk about, necessary skill, we're going to have them practice it right there. So see it, hear it, and do it. And of all of those, the doing is the most important, my 2 cents. Okay, another approach, group is vital. Why is group vital? Every good treatment center out there is going to have a group component. And why do they do that? Well, number one, we know that pieces that are vital for recovery, support, and accountability, there's lots of different ways that can be achieved. The support in a group provides connection to other people. It provides the reward, as we said, that long-term reward versus the short-term dopamine. It's going to tap into other reward centers in the brain. Reduce shame. A lot of people, when they start using and drinking, don't share a lot about that. And so they never test out if anybody else has done that, felt that way, right? Shame tells you to be quiet. And so you never get to know if anybody else is going through the same thing. So group helps reduce shame, and shame is a part of the addiction cycle. So we want to reduce shame. Group helps with accountability. If I'm going to say, okay, tonight you're going to have this conversation with your mom. You've told everybody in the group here. Will somebody in the group remind, Susie Q tomorrow that we're going to check in with her on that? So we provide accountability. Somebody put in the chat, helps with build trust, helps with the universality. We're more alike than we are different. So have someone to call or reach out so they'll stay out of their head. That's right. So in group, I may say, who in this group do you feel safe with? Okay, Susie, you feel safe with, Deborah. Okay, let's have you agree that you'll call Deborah if you need. And sometimes people are going to use the group before they use some of those other outside folks. Yes, accountability partner, normalizing feelings, group is vital. So we want to go low and slow. We want to see it, hear it, do it. And if you're doing the do part, right, the practicing, you think that's easier in an individual session or a group session? I'm going to give you the answer. It's easier in a group session if you're role playing, because you can have different people play different roles, and you can have the therapist observe and give feedback. So yay, Jacori, that's right, in a group. So when we go low and slow, we do it in a group, and doing the see, hear, do, doing the do part is going to be much more effective in a group. Sometimes we have people in a group setting who have a lot of social anxiety. They may not want to role play. And so you'll say to the group, would anybody in here be willing to role play for Jasper? Jasper doesn't feel comfortable doing it. Two guys may stand up and say, yeah, and they'll role play it. And Jasper will still be able to get the benefit of that do by watching others. So there's a lot of great things that we can do. And somebody mentioned psychomotor. And so you get a big gold star. My mom is a private practice, and psychomotor therapy is one of her passions. So yes, the more that we don't have time to talk about that, but the more we can engage the whole person, body, brain, emotions, the more the information we present will stick with them, and the more that's going to have an impact. So perfect. We want to involve the family and educate them. And we're going to talk about skills training. You can do the same skills with the family. The family has been on the same journey with the person with a substance use. They're going to need the same skills, identifying emotions, expressing emotions, finding their own motivation. They may have things that they want to do, goals around not enabling. You can do relapse prevention with them. So if you learn these skills and you're utilizing them with the patient, you can use the same ones with your family. And in fact, I encourage you to, because then they have the same lingo that they're using and the same experiences. And somebody says, yes, one needs to be careful how you partner up people. Absolutely. And we use gender-based groups here. And yes, that can be tricky. So know your people before you partner up. So the most evidence-based researched approach there is to treating addiction is cognitive behavioral therapy. There are a million variations on that, as Dr. Leish was presenting the community reinforcement. I'm not familiar with that, but behavior chaining is CBT. It's also part of DBT. Motivational interviewing uses components of CBT. Smart recovery uses components of CBT, and so do the 12 steps. I mean, what are you telling folks? Change your people, places, and playgrounds. You're telling people about stinking thinking. So CBT has been formally used for a while, but informally quite helpful for decades as well. And a lot of people think they're doing CBT, but they're really not. It is worth studying on its own. If you haven't, probably you'll have, but we want to work on the way somebody thinks to change the way they feel, and on specific behaviors, rewarding and growing those that are healthy, and slowly working on and decreasing those that are unhealthy. And it is like that. When somebody comes in, they're going to have a lot of unhealthy behaviors, and we can't expect that just to go back. So we're just reinforcing the positive and trying to slowly extinguish the negative. So motivational interviewing is what we use for our Dimension 4 work on your treatment plan, finding what matters to them, instilling hope, instilling the belief that they can make the change, that they are able, and you find ways for people to hold themselves accountable. I added bullet points after I turned these slides into Ashley, but motivational interviewing, like we said, it's a variant sort of CBT, directive, client-centered, and we do want to identify skill gaps. So motivation occurs when people believe that they are able to do something and we give them the skills. So it's about moving people from contemplation or preparing to make a change into action. All right, I want to spend some time on DBT. DBT is short for dialectical behavioral therapy. We're going to use this really mainly with our treatment planning around Dimension 3, somewhat 4, 5, which is our relapse prevention, because this is very skill-based, and with interpersonal effectiveness 6. So DBT was developed by Marsha Linehan to address those with borderline personality disorder that were chronically suicidal. And it is a version of CBT. So it's heavily cognitive, heavily behavioral, heavily reinforcing positive behaviors, extinguishing negative. And we don't extinguish negative by punishing people. So just to clarify that. So DBT is a therapeutic approach and practice. But we can take a piece of that, which is skills training, and use it with folks in early recovery. And the research on using this in folks with early recovery is amazing. So we're not doing DBT therapy, but we're doing DBT skill training. And we can do that. And if you'll just look at these 4 different skill training modules that DBT focuses on: distress tolerance, so being able to handle big emotions, get through a crisis, how to balance yourself out, emotional regulation, mindfulness, which is a practice we all know is helpful for those in recovery and helps with that Dimension 4 as well, around spirituality, connecting to something bigger than yourself. So we have the mindfulness, and then the interpersonal effectiveness, which is how we're communicating and interacting with other people in our lives. And it helps the patient learn to be successful, how to make a request, how to share a feeling, how to deal with it when you mess up, and how to make amends, right? So all of this totally relates to our folks in early recovery. So we're not going to do DBT therapy with them. That's a whole nother approach, but we can do DBT skill training. And this also, if you learn this DBT skill training, it's the do part. You're going to practice mindfulness with your patients. You're going to practice distress tolerance skills. How do you make it through a crisis? The cognitive behavioral therapy part, they're very big on giving your patients, your clients, homework. So when they leave your group or your individual session every day, they're going to be asked to practice a skill. So again, you're teaching it, they're hearing you talk about it, they may see you do it, and then they're going to go home and practice it or practice it in group. Any questions so far? And all of these DBT skill groups, you can find 10 skills under each of these headings. Google. And they are great things. You don't have to even tell your clients they're DBT skills. They're just skills, and DBT sort of packages them in these helpful modules, but they're just great skills for anyone. Lots of skills about handling stress, which is a big part of preventing relapse. And then we do want to, as I said, how do we do or address dimension 6? Well, as we said, there's the big picture, which is everything we're doing as relapse prevention training, but also there's the more granular level. So the approach we use here, we do DBT skill training, but we also use the book Staying Sober and Gorski's approach to relapse prevention, which has people self-assess what their warning signs are. And like the behavioral chain analysis, go back as early as they can and identify the earliest warning signs that something's not right before it's become a big problem. Because by the time something has become a big problem, most of us, it's gotten too big to handle. So we want to identify early warning signs. We want to share those with people close to us in our support system. And we want to make some commitments about what we're going to do if we see these early warning signs. So an early warning sign for me might be scrolling through old pictures of this person I used to date who used. And if I do that, I'm going to tell the group and I'm going to commit to, this action. So it's very individualized, and we have to have buy-in from our clients. So they have to determine what their action plan is going to be if these relapse warning signs occur. So let's hear from y'all. Some questions. Again, we could do, 2 hours on any one of these things, but this is just an overview and looking at what we need to address with our folks who are working on their recovery and some general principles about how we do that. Any questions or comments? I mean, probably y'all, you've put some great things in the chat of some things that you're doing.
Bronwyn, I'll throw a question out there.
Oh, good.
Because I'm not, while we wait for everyone else.
Yeah.
I'm sometimes not certain how to respond. Sometimes patients will have this take of, Doc, I've been doing this 20 years. I really don't need to go to group. I've heard it all. I could do it myself. I could teach it. And so what's a good way to approach that patient?
And we get that too. And I experience that 2 ways. Number one, I experience that person is probably having some shame, and feeling embarrassed that they have done it so many times and not wanting to participate. So I typically, and then 2, I also, I get it. If you've taken a class several times, you don't want to take it. So I sometimes validate, and then I also challenge them. It's not necessarily what we'll do in there, but your relationship to it and how you approach it. And I think especially when we're doing more of the doing, we can say, you know, everything we do in there is going to be different because it's based on us experiencing it in the moment. And sometimes if I'm being a little manipulative towards a greater good, I might say, well, good, we need experienced people in there. You can help me teach some of this stuff. That's going to be great to have you in there and help some of our other people, you know, and you can sort of appeal to their altruistic self.
Ooh,
So
that
somebody
sounds-
says staying sober, super helpful. Yes, I love that. Son's last treatment program, DBT skills, they're amazing. I mean, we use them all the time. We use them. We had somebody the other day, and I got this from the DBT training and from sitting in on a treatment program for borderline personality disorder. The person wanted to change counselors. That's very common. My counselor's mean. My doctor won't write me just what I want. You know, they want to change. And so the counselor said, okay, do a dear man, which is their approach to making a request. So that they had to like write out, you know, describe what I want and ask for it. And it was a really nice approach. So love the DBT skills. Oh, somebody said, when I encounter a Dr. Leish, they said when they encounter a response like that from patients, they use a strengths perspective and help them think about how their experience may help others. Yeah.
And there's a question in there about, is it better to concentrate on being sober before trauma treatment? I'm also really interested in that too, because I do get a lot of patients with PTSD and co-occurring substance use.
I mean, that's the most complex question we deal with. Can you do one without the other, which is primary? I believe, I'm a believer in it's all primary. It's all big stuff. But there are protocols with DBT, with EMDR, with CPT that somebody does cannot be under the influence of alcohol or drugs when you attempt it. That would be unethical and could possibly do damage. So how much sober time does somebody need before you attempt it then becomes the question. So I would want somebody to have some time sober and then to at least have some skills around distress tolerance, which is getting yourself through a crisis so that somebody doesn't harm themselves. And then for trauma treatment, it is sad, but there's a big disparity with income levels because the safest way to do trauma treatment is in a 24-hour setting because of the intensity of it. And no insurance even pays for that. So, but if we're doing it on an outpatient level, then doing it over time and low and slow. And I'm a big fan of DBT and CPT. So both cognitive, but just taking it really slow.
All right, awesome. Thank you guys so much for being here today. Both Dr. Leish and Bronwyn, you had excellent information. I just wanted to give a couple housekeeping things. I just put the link to the evaluation in the chat box. Like I had said at the beginning of the presentation, it should pop up on your post attendee page from Zoom. And then I'll also put my email in the chat as well in case you'll have any issues. And then at the end of the evaluation, you'll find the CE request form. If you'll just fill that out, I will get your certificates to you within the next 7 days. We appreciate y'all and your participation.
Can we leave it with this one person who just shared, I have more than 49 years in recovery. I'm so grateful for this life because it started off down and dark. Life in recovery is life. So somebody just shared that on our chat. So I think that's a great, thank you for whoever shared that. That's beautiful.
That is wonderful. All right. Thank you guys. Bye-bye.
Bye.